So our last speaker is going to be Ron Blaustien, who's our Chief Financial Officer here at Lurie Children's Hospital. He's been our Chief Financial Officer for the last year and is on the rise as a financial analyst of major hospitals. Just to put it in perspective, this hospital that you're sitting in is about a $1 billion unit. We're very proud of the facility, but here you're building a huge facility, what we consider one of the premier children's hospitals in the region, in an area of shifting sands, as you've seen, with mergers and acquisitions taking place. What do we go through on a daily basis to see that remains solvent? We couldn't have a better person than Ron Blaustien helping us to answer those questions.
I know you know your way around a computer, but
That's okay, Drew.
I'm here.
So, by the way, Drew's had a hard day today, but he is our AV extraordinaire here, so
I just
give
had
him
a-
some kudos as you go
I had a
out.
really fun night. It is Saturday, so give me some.
Yeah, Saturday.
All right, which one's
your?
yours? Yeah, there you go. That's you. All right, there you go.
So I had the fortune here of going last, and so I'm going to just let you know how I'm going to wrap things up here. We heard from Professor Hughes, and I had the fortune of learning with him back in early 2000, and about what's going on with cost and so forth in the industry, and from Henry about the struggles around mergers and acquisitions and what can be done and what the government's going to push back on and so forth, or the market's going to be able to handle. And then Mike talked a little bit about mergers and acquisitions, and I'm going to wrap it up here, kind of giving some perspective on other ways of managing the changing environment other than mergers and acquisitions. I'll touch on a little bit of where we've done that as well, but and I think to Mike's point, we've been approaching this really trying to engage our medical staff, and that's why we've done the sorts of partnerships and relationships we had, because in each one of those cases you'll see there was a different way that we thought would work in terms of that engagement, and I think we've been very successful. So I've been here for 9 years, saw us through the move here that we made 3 years ago from Lincoln Park, and Maureen Mahoney's in the room here. She was the one that really got us moved into this facility, and I'm very proud of it. So I'm going to take 2 minutes to toot our horn here a little bit, because you gave me the chance. So first of all, though, I wanted to point out that our mission, just like many other academic medical centers, is kind of complex, because we're trying to deal with the healthcare delivery, the research. We have a very large research enterprise here, the education of our future pediatricians and specialists, and then advocacy. We do a lot in the state and around in the government, the federal government, with advocacy, because there aren't that many people that are willing to speak up. And so in doing that, we have a pretty complex organization that includes the hospital, but also other relationships with our physicians, with our foundation, some newer organizations that have come down the road here. And I'm not going to go through each one of these, but just to give you an idea of the complexity. So that makes bringing on other organizations or connecting with other organizations very complex. Who are we, just to give you perspective then, as I walk through our arrangements that we've got. 4,500 compassionate nurses and other staff, 1,400 physicians, and I'll talk a little bit about how we're structured, in 70 pediatric subspecialties, so we really try to do everything for every type of patients. We have a lot of volunteers. We serve about 175,000 patients each year, 600,000 visits, and 288 licensed beds, which is fairly small for the sorts of things that we do in the state. We're the largest Medicaid provider, even after Cook County here, for kids, and the only standalone pediatric hospital. With that in mind, and I didn't put a slide here together, but I think it's worth noting that here in Chicago area, while we are the only children's hospital freestanding, we only make up about 25-27% of the market share, and that's consistent with some of the other hospitals, adult hospitals too, in terms of this matrix of many different academic medical centers and the market share split up. So you could say that's ripe for mergers and acquisitions, but in some ways it makes things more difficult. So lots of accolades. I'm not going to go through these, but this is what we focus on in terms of whatever we do. We want to maintain that brand. We have a culture that we want to maintain, and that's how we look at some of these relationships. So this is a list. I broke it out into 5 different areas, but there's probably more, and you might group some of these together. But we do, and I'll go through some of these more than others, but we definitely have some model here where we employ physicians. We have a medicine group and some other specialists that are employed by our hospital, 460 of them. But we also have a relationship with our surgical foundation, which is pretty dedicated here to Lurie Children's, where it's more of a contractual arrangement. We have an academic grant that provides for us to support the needs out there so that we know, for example, you're not going to get paid very much for Medicaid, but that's our mission. And so we want to be able to support that and still grow in that area as well. But definitely the academics and all the other admin situations and support that we need to make our hospital successful. And so we do that with our pediatric surgeons as well as our anesthesiologists. We have outreach partners, and I'm going to walk through that in a second. We've dealt with some of the new models of care with new businesses that we've put together and new arrangements. And then we definitely have had some acquisitions along the way that we've done that we thought were pertinent to what our business is about. So I wanted to step back to the outreach partners, and this is a map here on the side of the Chicago metropolitan area, and these dots represent different relationships among partners, whether just outpatient centers that we have at other hospitals or on our own, partner hospitals where we provide neonatology support or surgical support or ED support for specialized children's ED. And then we have a new relationship with a transitional care organization that I'll talk through in a moment. But as you look at these partner hospitals, you can see they vary among many different hospitals around the city. And this was our way of kind of maintaining a brand, but also knowing that we have to provide access in the proper place. And I would argue with Professor Hughes that it really is access that leads to the better quality and to the reduced costs, and managing that access in a proper way. And maybe that's the same thing as quality. Okay, so maybe it's the same thing as quality, because what I'm talking about is, and you've heard this a lot, but the right care at the right place at the right time. To me, that's about access, but it results in improved quality because you're not doing that care in the place where it shouldn't happen, and you're doing it at the appropriate time. And part of our partner hospital relationship is all about making sure that when that patient needs to be transferred or needs to have a call to a pediatric specialist, that we have that communication readily available with the proper policies and procedures to make it happen at the right time, at the right place. That doesn't mean that we're going to transport every patient down here the second our specialist touches them, but it does mean that if they need a consult or get on the phone or telemedicine with the proper specialist, that person in that hospital knows how to do it right away. And I would argue that another piece to the mergers and acquisition relates to risk, and it could be financial risk, and maybe it is cultural risk, or maybe it's risk to the brand, but that's the one major issue with, as you deal with getting into some of these mergers or relationships, is that risk, right? We want to make sure it's our high quality and that there isn't mix-up in these handoffs that are occurring because of that. In terms of some of these new models of care, you could call them population health. Maybe they're not as far along, though, down that population health management continuum. But we've entered into some different arrangements here, some forced upon us, let's say, by the state, but others that we've stepped into ourselves. The care coordination component of this, I think, really is key, and that develops that connection with the faculty and with the physicians. It's, when you can start to ask yourself and look at the patients coming into the emergency department, why did they show up in that emergency department? And when you have somebody there talking to them and asking about it, that's going to really help making sure, again, that their care occurred in the right place. Maybe they shouldn't have been in the emergency department. Maybe you find out that the pediatrician sent them there because their practice was busy. Well, how do you change those type of things to make sure it's happening at the right place? So we've created a care coordination entity that can support both Medicaid patients, commercial patients, where we can put into place the structure that's needed to make sure that those conversations are happening up front, after the care, making sure that the patient's coming back and seeing the proper specialist or the proper care after, let's say, an emergency visit. Accountable care entities are somewhat similar as well, but while the first one really focuses on complex kids in our case, we've also understood that it's important to work, whether there might not be a complex kid today, but they could be tomorrow, and it's still that full range of care that we need to coordinate better. So we've worked on developing a company with 4 other hospitals, and then we've also jointly gotten together with the federally qualified healthcare organizations that provide a lot of the Medicaid, what would have been uncompensated before, but now has grown with the Medicaid program, to coordinate care and really figure out where that care should be provided and making sure that it's happening early on. And then finally, the clinically integrated network could be the start of these accountable care organizations. But for us, it was very important to do this with physicians, and it's really a physician-led organization. We provide the capital from the hospital, but it's physician-led. Even the hospital designees, there's 2 of us. One's a physician from the hospital management. The other one is myself from the financial standpoint. But the rest are all either pediatricians or specialists in the community that we can work together. We've got a system that can gather all the information that we can analyze together, and then we are looking to contract as well together. And while that's not a merger, it's not an acquisition, it's a way of working together, and now some of the rules and laws have allowed us to do that together and properly compensate those in that group, as long as we're clinically integrated, to do the right thing and incentivized in the right way. Right now, we have 630 specialists, 167 APNs, and 77 pediatric practices all around the metropolitan area, covering about 250 pediatricians. And again, they've got representation in this group to help us develop the metrics and things that we want to be tracking. And then finally, as we look out into the community and try to think of, again, ways that we're going to reduce our costs and provide better care, we recently acquired an organization called Almost Home Kids that was founded here in the Chicago area. They provide transitional and respite care in a home-like setting for children with complicated health care needs, ventilator children, and it's really meant to be a way to reduce costs from when in the past we would have to train families how to treat their kids and take care of the kids in the hospital, and we would have to take on all that cost of doing it in the hospital. Now you can do it at a facility where it's less costly, and you can get all the proper medical care, though, in a less costly setting, and not need to be burdening as much on the government or on the commercial payers in terms of the cost. That's a product that we're developing. We're trying to make it a turnkey product that can then be worked on in other healthcare organizations all around the country. But it was a niche or a place where we thought was important to help move things along in terms of the cost of care. So with that, just to get back to how we came across all these different plans of and actions that we took, this is our look at what's going on in the industry and our approach to that. It's probably no different than what many of your organizations are thinking about in terms of the high-value care and delivery of better health outcomes at reduced cost, given all these external pressures and so forth. But that's how we've developed some of our initiatives and where we want to invest and grow and so forth. So that's all I got.